everybody. Once again, thanks to SAGES, and this will somewhat build on the last talk, just from below, I guess. So should surgeons perform more diagnostic screening colonoscopies? We did analysis, a comparison of endoscopic localization error rate between operating surgeons and referring endoscopists in colorectal cancer. I have nothing to disclose, and neither do any of the other authors. So to begin, as you all know, colonoscopy is considered to be the gold standard technique in detecting lesions of the colon and rectum, with studies demonstrating sensitivity in excess of 90%. Although colonoscopy is highly accurate in detecting lesions, its ability to accurately localize lesions is less clear. Studies demonstrate localization error rates as high as 20%. And this is important because accurate localization is critical to surgical planning, especially for small endoluminal lesions, as well as laparoscopic surgery, where the surgeon lacks the tactile ability to palpate the colon or rectum. For these reasons, many surgeons, as you guys just mentioned, elect to perform repeat endoscopy. Studies demonstrate that the repeat endoscopy rate could be as high as 40%. In the vast majority of cases, this is done strictly for accurate localization, often tattooing. And therefore, it becomes important to have accurate localization at initial endoscopy. Yet there's very little literature assessing factors associated with localization error. And for this reason, our group was interested in assessing for these factors. But specifically, given that surgeons tend to repeat endoscopy for referred cases at such a high rate, we were especially interested in assessing the role of the association between localization error and the initial endoscopist. So the objective of the study was to compare accuracy of tumor localization at initial endoscopy between operating surgeons and referring endoscopists. So we conducted a retrospective chart review at the University Health Network in Toronto between January 2006 and August 2014. A total of 577 patients were included in the study, all who underwent resection for colorectal cancer at our institution. The exposure of interest, as I mentioned, was the operator of the initial endoscopy. If the initial endoscopy was conducted by the same person who did the final operation, they were put into the operating surgeon group. If there was a difference between the initial endoscopist and final surgeon, they were put into the referring endoscopist group, which consisted of both referring surgeons and referring gastroenterologists. The outcome of interest was localization error, which we defined as at least a one-segment difference in location at initial endoscopy and final operative location. So get to the results. First off is our patient demographics. You can see here the two columns representing who the initial endoscopist was, whether it was the operating surgeon or referring endoscopist. There was no real differences in these two groups with regards to age, sex, the indication for initial endoscopy, the surgical approach that was employed, or the location of the tumor. As you would expect, the operating surgeon group had a higher patient population with previous colorectal cancer diagnosis and a higher patient population with previous colectomies. Interestingly, we found that if the initial endoscopy was performed by the operating surgeon, they were more likely to tattoo that lesion at that initial endoscopy. And as you would expect, there was a higher repeat endoscopy rate for referred cases, 40% versus 8.6%, both of which were statistically significant. Next, we did a univariate analysis to assess for predictors of localization error. You could see here the two columns, localization error and no localization error. A total of 44 localization errors occurred in our cohort. And to cut to the meat, only one variable predicted localization error, and that was the specialty of that initial endoscopist. If the initial endoscopy was performed by a non-operating referring endoscopist, there was a 7.94 increased odds of localization error compared to those performed by an operating surgeon, and this was statistically significant. Next, we put these variables into our multivariate analysis, and once again, only one variable predicted localization error. If the initial endoscopy was performed by a non-operating referring endoscopist, there was a 7.966-fold increased odds of localization error compared to those performed by an operating surgeon, and this was statistically significant. Next, we look at surgical outcomes as a result of these localization errors. Just to reiterate, there was a 9% localization error rate for endoscopies performed by a non-operating endoscopist compared to 1.2% for those conducted by an operating surgeon. And these errors led to changes in surgical plan. As you can see here, there was a 6.1% rate of change in surgical plan for endoscopies performed by a referring endoscopist compared to 0% in the operating surgeon group. There was increased likelihood of incorrect segment resection, intraoperative endoscopy, and conversion to open, but these were not statistically significant. And finally, time to definitive surgery was prolonged in the non-operating endoscopist group. So to summarize, initial endoscopy performed by an operating surgeon was associated with a lower rate of localization error than those conducted by a referring endoscopist on both univariate and multivariate analysis. And surgeon-performed endoscopies were also associated with a lower rate of localization-based changes in surgical plan and a shorter time to definitive operation. So the question is, why do these differences exist? And there's really not that much literature looking at this specifically. It may be partly, in small part, due to differences in specialty training, but mostly likely due to differences in localization practices between these groups. Surgeons obviously have an intimate understanding of the surgical anatomy, but more so, they're highly invested in ensuring accurate localization because they will be the ones doing the definitive operation. Another confounding factor is that, building on what was discussed in the last presentation, is that there's no recommendations that really guide in localization techniques. No practice recommendations really exist to tell you when to tattoo and when to not. And at least this is supported by our study finding of higher rate of tattoo localization by surgeons and lower rate of repeat endoscopy. Limitations, obviously, it's a single center, single Canadian context. Due to the retrospective nature of the study, we weren't able to account for all confounding variables, but we felt that we included all the clinically relevant ones. And as I previously mentioned, lack of standardized endoscopy reports from external referring institutions made us, we were unable to basically assess other techniques with regard to localization. And to end, I would just add that further research exploring the factors influencing localization accuracy and why surgeons have lower error rates relative to referring endoscopists is needed.